Very good.
Okay, so this is the old hospital I'm working with. It's a hold from outside. It's very brand new from inside. Basic principle. Again, I'm not here to, put oil on the fire, but just some basic principle each time you see a patient. Nobody wants to have the head open anymore. That's a problem, but it's a fact. Endovascular treatment gives good result and it improves every year, which is also a fact. And another fact, it's more and more neurosurgeons do endovascular. They change their culture, and I think this is a good point. Having said that, let's have a look to what has happened to our discipline since 1975. This is what I call the obsolete treatment, the mature treatment, and the under-evaluation treatment. So let's stop about the balloon selective occlusion and the flow disruption. And let's have a look at what we call the mature treatment, which is coiled, self-expandable, mixing-your-balls, flow diverter. And I will add also the endosaccular device, which is a web that we are using since 2012. So it's not anymore a new treatment. It's a routine treatment in our daily practice. The guideline for selection of appropriate interventional neuroradiology approach is just based on few things. Your own philosophy and experience, it's absolutely important. Sometimes you are in a situation where there is no other reasonable choice, so you have to do endovascular treatment. And for the rest, it's at least 95% of the aneurysm, endovascular treatment is possible. So let's go quickly through what's possible with endovascular treatment, and then we'll see the potential concern that we might face in the other situation. So this is what we were doing in 1995. Why stenting with why balloon remodeling with coiling of the aneurysm, having this result after the treatment. Today, we have much more fancy tool to do it. We can deliver stent, we can deliver braided stent in a wide configuration and stent in the middle and get this wonderful result after the treatment, whatever the size of the neck of the aneurysm. It's another middle cerebral artery aneurysm. I took those examples just to, fix exactly what we can do in a very typical neurosurgical indication. This is a kind of aneurysm that you don't really see clearly where the neck. It's a very ugly looking aneurysm, but if you reconstruct the wide division with wide stenting, it's not that difficult to put coison in the middle and to get this wonderful result on a 3 months control angiogram. Another shallow aneurysm, again at the middle cerebral artery bifurcation, which is going around the bifurcation of the MCA. And again, with this proper selection of the stent, you can really do a wide stenting, put coil in the middle, get around the sac of the aneurysm, around the bifurcation itself, and finally got a very good result. Even the dissecting aneurysm of the pica, it's no more a real concern for us. We have the possibility to deliver a very small stent to put coils in the middle. And even today, I would do this treatment with a tiny little flow diverter. Well, this is the kind of result you can get after the treatment with a perfect exclusion of the aneurysm. So just for you to show what we can do. Now, the technology is evolving and we have the possibility to use also this endosaccular device, the web device, which is in this situation where the neck is clearly visible and the sac is very regular, a piece of cake, you navigate, you drop the aneurysm inside, and you find this 18 months later, a perfect closure of the aneurysm and preservation of the middle cerebral of the anterior communicating territory. When the aneurysm, again, at the middle cerebral artery bifurcation is ugly looking with a very wide neck, difficult to think that it's possible to do it with an endosaccular device. It's not true. You can deposit the cage inside the sac of the aneurysm, that is done here, and then you check. We have the possibility with this fancy radiological equipment to look at what's happening with the device inside the sac of the aneurysm itself, and we clearly see that there is a small remnant at the level of the neck. If you leave this like that, you have a chance to get recurrence at this level. So you have to get rid of these potential factors for recurrence of the aneurysm. So it's very difficult to tilt the device inside the sac of the aneurysm. You just pull and push on it. So one possibility to do it is to put a balloon at the bifurcation. Here you can see the balloon is inflated, then very progressively you deploy the web, and then you pull on the web. And by pulling on the web, as you can see here, you will see, puff, it tilts towards the bottom of the aneurysm, the neck of the aneurysm, protected by the balloon which is there. And having done that, you can clearly see the difference between what it was before and what it is after. There is a very nice apposition of the bottom of the web at the bifurcation itself. This is a wire of the balloon catheter, which was used to help this positioning of the web inside. And this is the follow-up. This is pre-op. This is immediately post. There is very frequently flow in the device immediately after the deposition. This is 1 day post. It's already almost completely gone. And this is 20 months later with a perfect occlusion of the aneurysm and a perfect healing at the bifurcation. Ugly looking aneurysm in difficult situation like blister-like, it's a concern for neurosurgical approach. It was a real concern for endovascular too. It's not really a concern anymore as far as we have possibility to use the flow diverter. And the flow diverter can be used in this dramatic situation in emergency to treat this aneurysm. As far as you care about the preservation of the patency of the ECOM, in this situation it was the case, you can just deploy a flow diverted stent covering the neck of the aneurysm and the branch, and even if it does crosses the origin of A1 segment, it's not a concern as far as there is a cross flow. This is a flow diverter, this is the aneurysm, and this is what you can see 6 months later. Aneurysm is completely gone. The artery is completely patent. The lenticular striate is patent, as you can see here. And you can also see that here, it goes through the lenticular striate and the aneurysm is completely gone. Looking at the vaso-CT, which is a special way to screen on the aneurysm with a CT in the angio suite. So this is a 6 months post-op just to compare to what it was before. So even in this very difficult situation, we have the possibility to do treatment. So forget about what we can do in aneurysm that are competitive or not with a neurosurgical approach. I would prefer to insist on the fact that a lot of indications are only depending on our philosophy and experience. And there is one thing that belongs to philosophy, which is a bypass. The bypass is really an indication based on your own philosophy. I have nothing against a bypass. I just want to tell you that there is an endovascular way to go around the bypass and to avoid the bypass. So this is an indication of what we were doing previously, which is all this 10 years ago, before we got the flow diverter. This patient had a partially thrombosed bifurcation, carotid bifurcation aneurysm, and this patient was treated by parent vessel occlusion. We occluded the carotid. It was not done here, but I would have done the same at that time. And, on the control angiogram, the aneurysm is still filled, and the distal part of the middle cerebral artery is perfectly visible. So when you look at this at that time, we did a treatment based on bypass. A high flow bypass was performed, as you can see, which was good patency, which is also supplying the middle cerebral artery territory, and the patient was really nice. The second step treatment was to occlude the aneurysm, the carotid aneurysm artery, and at that time we decided to do a control angiogram before the treatment, and this is what we saw. This is the right side, and this is the left side, and as you can see, there is no more aneurysm visible. Definitely, the competition of the flow, this is a superimposition, is clearly showing that because of that, the aneurysm has disappeared. The bypass is supplying the middle cerebral artery territory, and the ECOM is supplying the anterior cerebral territory. So this is a good result. So what do we do today? Today, it's a different song. Let's have a look at this aneurysm. This is a typical aneurysm, dysplastic, ugly looking, a lot of blister all around daughter sac on this dysplastic aneurysm. And of course, there is a possibility to occlude after doing a bypass surgery, but also there is a very simple way to do it, which is crossing the aneurysm, delivering a flow diverter, and this is what you get, a perfect reconstruction of the parent artery, and the aneurysm is gone. So this is really a tremendous thing. Let's have a look at this. This patient got a giant aneurysm of the bifurcation of the carotid artery. He had a bleed at the time it was discovered, and he was treated 2 times by endovascular approach by coiling of the sac of the aneurysm in another department. Everybody knows that this is not the way to treat a large aneurysm, and this is the recurrence of the aneurysm, wide neck, the portion of the middle cerebral artery, which is still patent and visible there, intricated with a bifurcation. So there is also a good indication for a bypass surgery, but there is also, as far as you have a different kind of experience, a possibility to just put a flow diverter crossing the carotid, supraclinic carotid artery to the A1 segment. As far as you bridge this, you just cover the neck of the aneurysm. So what about the patency of the middle cerebral artery? This is what's happening. Look at that 5 months later and 14 months later, aneurysm is completely gone. The parent artery has been reconstructed. And what's left from the middle cerebral territory is completely patent. So this is something that you have to, know. It's possible to do this kind of treatment just by covering the bifurcation as far as you maintain a high blood pressure for a while. It's another example of a ugly looking aneurysm, dissecting aneurysm with an entry and two exit. As far as you check the potential collateral situation, circulation on one of those two territories, you can know the one that you can bridge and the one that you can potentially include in the occlusion of the sac of the aneurysm. We can navigate bypass. There is a lot of possibility to navigate inside the sac of the aneurysm and have a scaffolding and then deliver flow diverter in the scaffolding. This is the VASO-CT, which is clearly showing that this montage has completely covered the neck and reconstruct the parent artery. Now let's have a look at what's happening. This is 14 months later. There is still a little bit of the aneurysm visible here, of this large partially thrombosed aneurysm. And this is a 3D picture. And this is 20 months later. The aneurysm is completely gone. The parent artery, which is a collateral exiting from the sac of the aneurysm, has been completely preserved. There is still a patency and a flow inside and no more aneurysm visible. So just for you to understand that this kind of difficult aneurysm, which is a potential indication for bypass surgery, is also a very good indication for intraluminal parent artery reconstruction, just for you to understand what it was before the treatment, and this is the patient after the treatment. Now, let's have a look at this difficult aneurysm. It's an aneurysm which is at the distal part of the carotid, supraclinoid carotid, just at the origin of the middle cerebral artery territory. This is the PCOM, as you can see. This is the posterior circulation. There is no supply from the A1 segment. And this is the injection from the vertebral that you can see. You inject retrogradely through the PCOM, the aneurysm. So basically, the whole middle cerebral artery is completely intricated in this giant aneurysm. There is also a good indication for bypass and then occlusion of the sac itself or occlusion of the parent artery. But if you look at the anatomy, there is also a possibility when you go from the posterior circulation and then you come retrogradely through the PCOM and then you navigate in the first porch and then in the second porch and then you find the exit and you get access to the middle cerebral artery to do this kind of montage. This is a high pressure injection of the carotid. You can see the supraclinoid. This is the PCOM. It stops here. There is no A1 segment. And this is the beginning of the story of the aneurysm. And this is the opposite side, just to understand the potential crossflow from the circle of Willis. So what we decided to do is to navigate from the posterior circulation this way. So of course you cannot do that with one single flow diverter stent. So you have to do scaffolding instead in a telescopic way. And 3 different flow diverters were delivered coming from proximal to distal. This is the coverage and the reconstruction of the parent artery. This is the section through the montage of the stent, clearly showing the perfect reconstruction of the lumen of the vessel. And this is a 6 months control angiogram. You can see that was expecting has happened. The PCOM is supplying completely the middle cerebral artery, which has been reconstructed, considering that the aneurysm is gone. So there is no question that we can do a lot of things, despite asking. Or it's interesting to know what's possible to do. Then the choices, of course, depending on your philosophy and depending on your experience. In some situation, there is no other reasonable choice. It happens, and there is no question that it is the case when you are dealing with cavernous carotid aneurysm, which is responsible of cranial nerve compression. Today, nobody thinks about doing something from inside. Everybody is reconstructing the parent artery by delivering a flow diverter stent in the carotid siphon to get this wonderful result 14 months later. Nobody can think that this patient had an aneurysm if you just look at this picture. So this is definitely the way to go. There is no question about it. Now, let's have a look at this situation. Think about the possibility to treat this aneurysm. Surgery, I don't think it's easy. Endovascular, it's not easy. Plus, you have to choose the proper tool. You know, there is a big concern in our discipline, which I hope will be yours one day. We have so many tools that it's difficult sometimes to choose which one is more suitable in a given case. In this situation, there is no question that having a wire reconstruction and using laser cut stent, one which is not open cells and one which is open cell, is extremely important. Why? Just because you know exactly how to protect and reconstruct the parent artery, and then you can go through with coils. So this is the aneurysm when looking at the angiogram, and this is the evolution of that aneurysm. Pre-op, this is immediately post. There is some dye going through the stent and through the mesh of the coil, and this is 8 months later, a perfect reconstruction of the basilar division, and the aneurysm is gone. So even in those difficult and critical situations, we can do something. Of course, we can do something in this ugly looking dysplastic middle basilar artery aneurysm. The real question is, should we do the treatment of this? I think today, with the kind of tool that we have, it's absolutely reasonable to do the treatment of this aneurysm. So the patient is treated very simply by delivering a flow diverter. The navigation sometimes is not that easy, but this is our business, so we are not going to complain. Let's have a look at what's happening. This is after the treatment on the right side of the screen, and before the treatment, the basilar artery has been perfectly reconstructed. The aneurysm is gone. It's not difficult, and this is also one of the beauty of the tool. In most of the cases, it's not that difficult. I'm not saying that you don't need experience. Of course, you need experience, but it's not as difficult as, for example, neurosurgical approach. Let's have a look at this patient who can do something unless you use the tools of the Century, which is a flow diverter. This patient is 15 years old. She presented a sudden headache with vomiting, and the CT scan, which was done the next day, was definitely demonstrating some bleeding in front of the pons. And we did an angiogram, and we noticed this dissecting aneurysm of the upper side of the basilar involving the superior cerebellar artery. How can you think that you will be able to do a treatment in this patient? There is something that you have to understand. Crossing a bifurcation is a concern because you covered some of the branch. But if you look at the balance of the flow, you have a lot of things that are possible. So this patient was treated in emergency. So in emergency, we put the patient under abscisimax, and we delivered the telescopic stent, which is a pipeline in this region, and we covered the basilar, we crossed the aneurysm, and we covered the P1 on that side, and we went in the P1 on the other side. This is a perforator here. That's the reason why we choose this direction. So this is the immediate control angiogram. 1 day post-op, the patient presented with a mild left hemi anesthesia. And as you can see on the MRI, there's a tiny little stroke in the pons. And when we did another angiogram, we saw that despite the abscisimax, the patient is presenting a rapid thrombosis of the sac of the aneurysm involving the origin of the superior cerebellar territory. This is the angiogram at that time, which is 1 day post. So we stopped the abscisimax and we removed the Plavix to use the ticagrelor. We are not using Plavix anymore for the last 5 years. So ticagrelor was delivered to the patient. So this is the evolution of the patient post, immediately post-op. This is 1 day post, the one that you saw already. This is 10 days. Due to the treatment with the aneurysm, and we gave time for the flow diverter to divert the flow. And this is what's happening on a long-term basis. This is 5 months post-op. Aneurysm is gone. The arteries that have been cover are no more visible because there is another crossflow from the posterior circulation on the opposite side, and the aneurysm is cured and the patient is going well. So there is no question that this kind of aneurysm before the flow diverter, it was not really possible to do a real treatment and a treatment which is going forever. This aneurysm we already saw, and let's have a look at this one. You know, I saw during this webinar a lot of giant aneurysm, and basically, you know, the giant aneurysm, when it extends in the distal territory, it's something which is difficult. First, there is a lot of mass effect, but most of the mass effect is due to the edema around the aneurysm, and some of the aneurysm keep on behaving like a real tumor. So this is the thrombosed portion, this is the patent portion, this is the patent portion that you can see, and this is what you have. This is third M3 aneurysm on a small branch, which is obviously the angular branch, and we definitely need to try to preserve this angular branch. This is a different projection to see the aneurysm. Today, it's not a deal. You can just navigate very easily with a tiny little catheter, which is a 17 micron catheter, the same catheter as the one we use for delivering coils. You navigate in the sac, you get out, then you extend, and then you can deliver the stent. Sick baby was delivered in this condition. So this is the immediately post-treatment. You can see there is still some flow going through the stent. This is a VasoCT, which is a reconstruction of the CT done in the angiosuite. You can clearly see that the branch has been preserved and we are crossing the neck of the aneurysm. Now let's have a look at what's going on. The 6 months post-op angiogram is clearly demonstrating that there is no more aneurysm. In addition to that, the edema has completely diminished and regressed, and there is only the portion of the aneurysm which is thrombosed. So overall, after having your own philosophy of treatment, after looking at those cases where there is reasonable no choice to do except trying to do something from endovascular, the rest of the endovascular treatment is more or less most of the aneurysm can be treated by the endovascular approach. I think this is a very important message for the future. How can you keep on, and we already discussed this, how can you keep on training neurosurgeons, understanding that with the evolution of the devices and the technology and the experience of the endovascular surgeon, we really don't need too much. Even the bypass surgery is going to diminish a lot because we have the possibility to reconstruct all the vessels that were potentially candidate for bypass surgery. So there is no question that it's a big point. Don't get blind, look at the future. It's not reasonable to keep on teaching neurosurgeons to treat aneurysm that they will not be able to treat in the future. This is a message. I know that you are going to react a lot, but if at my age, in my position, I don't say that, I think that I'm not helping neurosurgery. Thank you.
Thank you, Jack, for this wonderful presentation. And I just see Dr. Poggi, Giovanni has one comment or question. It's a wonderful presentation. And I agree with the statement you mentioned early in the webinar that train your people to the advancement, don't stick on something that you might not be using it 100% in the future. And as you said, the American way, now the young neurosurgeon, they will be trained for both. It's always difficult because a human being has always a dominant hemisphere that will dictate on him which he has to do. And there will be some bias, but at least for somebody who has the training, then he will understand when he see these like flow diverters, pipeline, stenting, the value of it, and they start considering the approach over the others. Giovanni, you have comment or some question?
Well, I would like to make a comment about this last statement. Definitely, the future to have, first of all, compliments Jacques for all the presentation. In the future, definitely, we have to have a vascular neurological surgeon. That means that we'll be able to do interventional and surgery. Like, for instance, my friend Giuseppe Lanzino is doing in the United States. But at least in Italy, there is a law that is against that, because radiologists are against this project. That is the problem that we have in Italy. But that's we will overcome. One question to you. Wonderful. You show that you can treat almost all aneurysm or giant aneurysm. My question is, when the giant aneurysm is clinically presenting itself as like a tumor, not like a rupture, you close the aneurysm, and that's wonderful. Who take out the tumor?
Okay. You know, I'm not pretending that everything is a piece of cake. You know, the giant aneurysm, it's a different song. A giant aneurysm might behave like a big tumor, even when it's completely excluded from the circulation just by the triggering of the angiogenetic factors. So this is a big concern. But let's have a look, frankly, about what's happening, you know, most of the time. What's important in giant aneurysm is the edema, which is surrounding the aneurysm. And after exclusion of that, the edema, most of the time, just disappears. So even if you keep, you know, an aneurysm which is shrinking, it's not disappearing, but it's shrinking. With time, the mass effect most of the time disappears. Now, suppose the mass effect doesn't disappear and you need to do something to remove, surgically speaking, the mass effect. When the aneurysm is excluded, it's just a piece of clot which is organized. So you can cut inside, you can do what you want, and forget about treating the aneurysm. You just remove a tumor or portion of the tumor. It's not going to grow again. You just remove portion of the tumor, portion of the thrombosis, and then you give space, and then you remove the mass effect. So I'm not saying that the mass effect is always disappearing. The mass effect is disappearing most of the time because of the edema, which is disappearing. If it doesn't, then remove it surgically. It's a tumor surgery. It's no more a vascular surgery because the aneurysm is already excluded from the circulation.
Any other comment?
I have a question.
Vladimir.
Yeah, Jacques, that's extraordinary what you are doing with this flow diverters. We love them also, and I believe that this is really the treatment of the vessel, that the vessel gets healed. However, there is a delay between the procedure and the final result. Several weeks, months, whatever. We have never seen a rupture during this period. Did you see a rupture during the period of healing?
Extremely rarely. Probably less than 1%. Probably less than 1%. You know, the very important point, we were not believing that. Those blister-like aneurysm, it's a hell. It's a hell for everybody. Okay? Putting a flow diverter under antiplatelets treatment is the way to go. The complications that are related to bleeding after the delivery of the flow diverter is very, very rare. What's not that rare is in the meantime you need to get a complete exclusion of the aneurysm for waiting for re-endothelialization of the wall, the blister-like aneurysm might keep on growing. You know, we have cases where we were obliged to do 3 different treatments, putting flow diverter to get rid of this aneurysm. It was not bleeding, but it was keeping growing. You know, not everything is not solved, but it's evolving dramatically. And, you know, more and more in difficult situations, I think emergency is not a real concern. The concern is, when do you do the external shunting? You know, when the patient needs the shunt, you know, you better do it before, because then the patient is fully loaded with antiplatelets treatment. And this is another concern. I would definitely love to know exactly what we can do, surgically speaking, when you have a patient who is completely filled up with antiplatelets treatment after our treatment. There is a lot of potential complication. Some neurosurgeons are really afraid of that. Some of them are less afraid. Some of them are not afraid at all. I don't know. I need an answer to that. You know, I have been asking my friend Jua, what do you think? Most of the time he say, I don't care. If you do hemostasis properly, it's not a concern. A lot of neurosurgeons, they don't think the same. So this is a big concern. It's a big concern.
And
Let's see, I have
it a bit. Imar, let me. I have heard your lecture some 20, 25 years ago for the first time. Already at that time, you were telling that there is no future for vascular neurosurgery, that there is no future for aneurysm surgery. How would you explain that we are still there now?
Oh, very simple, very simple. First of all, radiologist, neuroradiologist, myself, we were stupid enough, we are stupid enough, I was stupid enough, I am no more, to manage a patient without controlling the bed. If you don't control the bed, you don't have the power on the patients. And this is your strength. You control the bed. If you control the bed, you control more or less indication. You know, we are not going to do something in your bed that you don't want to be done. So this is a big, big concern. The second part, you didn't believe too much in the endovascular treatment originally. So it took time, definitely. Now you believe. Now you get training. Now you are taking over the business. And I don't care. Honestly, being a neurosurgeon or being a neurologist or being a gynecologist, if you get the proper training and if you do it properly, I am okay, you do it. The worst is to do something that you don't master. And the third point is, unfortunately, worldwide, we don't have access to the same devices. And this is a big concern because of regulation, because of money-wise, because of whatever. You know, I know a lot of countries in the world, they don't have access to all the devices that we have. Plus, in addition, if the patient cannot pay, he cannot get the treatment. You know, I am in a situation which is extremely favorable, you know, because I don't care about the cost of the treatment. I care about my salary, which is miserable, but the patient is fine. He doesn't pay anything. And I love this. Honestly, I love this. If they increase our salary a little bit more, it would be better. But nevertheless, this is the system. So, you know, there are many, many reasons why it's not growing that much. But honestly, most of the time, all around the world, it's not more than 20 to 25% of the aneurysm overall treated by neurosurgery. The rest is going through endovascular. Look at China. 10 years ago, they were not doing that much. Today, they're extremely good. They have developed a good technology. They have access to the to the devices, not exactly the same devices as the one we have, but it's growing dramatically. You know, 1.4 billion people are now exposed with good doctors, with a good training for endovascular treatment. So it will go this way. I am 100% sure that less and less neurosurgical approach will be done. It's not a problem. It's the same discipline, and we are dealing with the same patient. So don't complain. You know, we are not, don't complain, you know. The best pasta in the world is in Italy. So, okay. So try to copy and don't complain.
Some 15 years ago, we managed to start the program or to put on paper the program of education for neurosurgeons to do endovascular, along with Pierre Lajanet. It somehow is still in effect within the European Union. But it's exactly the same what Giovanni is saying. We do not have the access to the X-ray machines. They don't let us. The same as you do not have the access to the beds, we do not have the access to the machines. And there was no help from your side over the years. We are the ones only pushing this education, this common education for endovascular, for neurosurgeons. But never ever any interventional radiologist helps us to push this through.
So Vladimir, yes. There is a very simple answer. In 2015, we got those 5 studies, randomized study about the stroke. What's happening today? 5 years later, neurologists, they have never access to angiosuite 5 years ago. Today, a lot of neurologists are doing endovascular treatment and endovascular thrombectomy, and they have access to the angiosuite. No, everywhere. In United States, in South America, No, in France, it's not. In France, we have access to neuroradiologists. I know there is a lot of regulation, but forget about the regulation and think about the future. The regulation, they are here to be adjusted. So if we fight enough and if we are clever enough, we can manage a way to change the regulation. Europe, for the time being, can be one of the territory where it will be possible. I don't know, but think about what can be possible. If it's not possible for political reason, for I don't know, then it's a shame for the patient.
I fully understand you. I understand that this is the future, no doubt about that. This is the same as vascular surgery. It's over. It's a past discipline.
Yeah.
But I don't know about Giovanni. Have you ever had a success? Do you have any neurosurgeon doing interventional in Italy?
Not in Italy.
Not in Italy.
In Italy, you have to have the board of neurosurgery and the board of radiology. That means a lot of time. Very few people are prone. Plus, the radiologists, I'm sorry to say that, are very conservative and they don't want to have somebody in their garden. That's the problem in Italy. I don't know what is around Europe or around the world. United States is a completely different situation. They can do both, but that's the United States.
Right.
But Giovanni,
yeah, go ahead.
I think it's not necessary to change a label on your jacket.
I think just wait a minute.
Yeah, the only thing you need is to be concerned about this problem. As far as you are concerned, you work all together in the same environment, the same bed, the same staff, the same everything. You know, it's not because there is one single department that, you know, you will be doing everything. Some will be doing endovascular and some will be doing open skull surgery. It will be exactly the same thing. But for the power of the discipline and the future of the discipline, we need unity. We definitely need unity.
Okay, I have IP Sherry.
In our studies, we have a neuroradiologist who is a part of the team and who is doing all the interventional work. And there is not a single patient in whom we perform any endovascular treatment who is not at the neurosurgical department. And it works well. This is one of the ways how to overcome this stupid, we call it nuclear law, what Giovanni was talking about. That was put on the paper that we can handle provided there is 1 year of training in a respected place, you know, and then another one at home. We put it together with Pierre Lajanet, and it took lots of time to put this together. But then you hit this nuclear law. In my country, neurosurgeon who would like to do endovascular, he would have to have a attest in radiology. It means that for a year or two, he will be describing lungs and broken legs. No one will do it.
I think, yeah, this is a problem all over except in the US and some areas now. But right. I'd like to commend Jacques about his objective ideas that unity is important, work in collaboration, and it's time for changes. The problem, as you said, they want the neurosurgeon to do radiology physics for 4 years, and he will lose the expertise on both sides before he starts anything else into endovascular. But let's hope the best, and I think we just want to not to put this arena, but this is an important discussion for the trainees because they want to see if they can attend or they are just go for 1 year or 2 years or 3 years, and then they should be like in the US system. We should adapt this system actually. IP Sherian, he has one comment, I don't know, from India, please, IP.
Hey, Imad, thank you very much. First of all, Jacques Moret is a legend. There's no doubt. Excellent lecture. And best of luck with the dream that vascular surgery would disappear. I don't think that's going to happen for a long time, another 25 years more at least. I wish I could say that the cost doesn't matter, but it is not so. 5/6 of the world is low and middle income countries. And it is unnatural to have a treatment which is costing 100 times. And this is being pushed into all these low cost, countries where people cannot really afford. I'm seeing it in India. I have seen it in Nepal. And thanks to this, the skill of clipping, the skill of bypass is also disappearing. And again, as you said, clippers has also been stupid because aneurysm clips have never advanced, while the devices have advanced so much more. Aneurysm clips have never advanced. So while I would say this would be part of the future, I wouldn't definitely say that this would be the future and vascular surgery would disappear. As long as countries like India, South America, Africa would exist, and as long as this economic system would not change, I don't think we can ever say that cost doesn't matter.
Yeah, nobody said that.
I'm sorry.
No. Yeah. Go ahead, Jack.
Cost is always a point where the discussion stops. Cost is a real concern. I agree with you. But there is no concern with any solution. There is always a solution. Second, if you look at the countries where it's supposed to be too costly to be used, look at the distribution of the devices. Why the same device is costing 3 times more in somewhere, I will not say the countries, compared to what we pay in France or what we pay in Germany? Because even in Germany, it's cheaper than in France. Why? Tell me why. Because along the chain of distribution, this is a 10% step. Each time there is a step, you take 10%. So at the end of the scale, it's 3 times more. So this is a cost problem too. So, you know, be frank with everybody. You know, as far as we speak about cost, we have to be frank with everybody and to speak honestly. The cost is a concern, but there is nothing that you should never forget that the cost depends on if you buy or if you sell. There is always a bargaining and there is always a possibility to find a solution, depending on if you buy or if you sell. Cost is a concern, but it's not a concern with no solution.
Okay, well, Jack, well, thank you very much for sharing your experience. Your thoughts is tremendously of value for the future of this practice.